Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are continuing on with our Heart Health Month. Today, we're going to be talking about rebuilding heart health with cardiac rehab. I have Mike Urquhart here with me. He is a PhD and an exercise physiologist with our TMC cardiac rehab program. How are you, Mike?
Hello, Maya. I'm doing very well, thank you. Thanks for asking.
We haven't had you here in a while, and I love when you get to come because you get to tell us all things about all types of exercises, everything that is important for our heart. So, and you get to talk about, I think, something that you're extremely passionate about, and that is cardiac rehab as well.
Exactly. Yes.
So I'm going to go ahead and put your PowerPoint up. You do have an online audience along with folks that are watching in person. So if you're watching from home, please go ahead and leave any questions or comments for Mike in the chat, and I will address those afterwards. Mike, I'm going to turn it over to you to get started.
Excellent. Hey, thank you, Maya. I've given a lot of presentations here about exercise, and that's great. I love talking about that. But every time I give one of those presentations, I talk a little bit about cardiac rehab and have always wished I could talk more about cardiac rehab. Well, now I get a whole presentation to talk about cardiac rehab. I'm TMC cardiac rehab. There's about, six of us physiologists that work directly with patients in cardiac rehab. When I'm at the hospital, what I talk to patients about is exactly what I'm going to talk to you about today. What is cardiac rehab? That's what a lot of people, that's their first question. A lot of people don't even know about cardiac rehab. I usually start off by saying, well, cardiac rehab, it's like the NCIS of investigative services. Yeah, okay, nobody gets that joke. But um, cardiac rehab, it's a very large organization. It's spread throughout the country. TMC is not the only hospital that has cardiac rehab. There are a lot of different centers around the United States. In fact, there are 5 different cardiac rehabs right here in Tucson. But of course, the best one is TMC Cardiac Rehab. Um, do I have to say that? No, but we are. Um, Anyways, what is cardiac rehab? And that's what people ask me all the time. So, cardiac rehab. Oh, and thank you. Thanks for having me here. I'm also a professor. I teach nutrition, I teach biology. And so, standing behind a lectern, that's not me. I can't, it's hard for me to stand behind one of those things. I usually use PowerPoint slides just to keep me on track because I will tend to go off track a little bit too. But thank you for having me here, Maya. Thank you again, Jen. Thank you for having me here again. I really love coming here. But anyways, cardiac rehab. Oops, went the wrong way. So, uh, what cardiac rehab does, it helps people that have had any sort of cardiac issue. And so typically people that come to cardiac rehab have had some sort of heart condition. Some of the more popular, some of the more current diagnoses might be blocked arteries, things that you might need a stent. And basically what this picture is showing, what happens to your blood vessels over time, they start becoming occluded. At the process of atherosclerosis, you start building up plaque on the inside of the arteries, and it slowly starts to occlude the arteries to a point where they are completely narrowed and completely blocked. And so during that point in time, and you can see an example here on this slide. I know you can't see me pointing people online, but it's a progression over time. About every 10 years of our life, starting at about age 13, 14, 15, we have significant increases of plaque buildup. And so when towards our late 50s, 60s, that's when we start feeling the effects of some of those occlusions. Now, a cardiologist in their right mind would never do any sort of intervention for somebody that's like 40 or 50% occluded. They would just tell you, go out, exercise, eat right, maybe put you on a statin, maybe give you blood pressure medication to help slow that process. But it's eventual. I mean, it's something that's going to happen. And so, anyways, once that process happens, some of the remedies for that are cardiac stents, balloon angioplasty, where cardiologists and interventionalists will go in, usually through your radial artery or through your groin, and just fish a little wire balloon and then expand that occlusion. They might put a stent in there, or they might just pack that occlusion to the side, spread it out so that they can open that artery up. And all of this blood supply is to the heart. All of this blood supply is so that the heart can stay functioning, because your heart is a pump and it pumps the blood throughout all your body. And once the heart goes down, if it slows down, then of course all the systemic circulation goes down as well. So all of this happens within the muscle tissue of the heart. Okay. Now, another remedy is what we call a CABG, or coronary artery bypass graft. And coronary artery bypass grafts, the one that's pictured here, this is a ×2, CABG ×2, where we have two. This is a vein that's harvested from your leg. It's called the saphenous vein. It comes from right down here. And this vein is grafted. It bypasses the blockage, goes from the aorta directly into the branching arteries that need to supply the rest of the heart. And then this other artery, this is an actual artery. This is the mammary artery. That is actually severed, and instead of going to where it was going, it now goes to a grafted area within your heart as well. And that's how you resupply. That's how a cardiologist and interventionalist, a surgeon, cardiothoracic surgeon, takes care of those blockages. There are other types of heart issues that may occur, like valve issues. There's a great, and I love talking about this procedure, it's called the TAVR, the transaortic valve replacement. And it's quick and clean. If you have any sort of valve problem within your heart, an interventionalist, and can I say his name? Yes, I'm going to say his name anyways, like Dr. Wagner, Dr. Buwala. They can go through your groin and replace that valve. No open heart surgery. They can replace that valve. It's like a 15, 20-minute procedure, and then you're done. You sleep for a little bit, and then you go home the next day. Some of the patients go home that day after having a valve replaced. Now you're wondering, Mike, you're talking about all these procedures. What about cardiac rehab? Well, I'm going to tell you, this is the real deal. So before all that happens, before that blockage occurs, before that surgery occurs, your body goes through a period of decompensation. You start getting weaker, tighter, you do less, your muscles atrophy, your cardiovascular system becomes suppressed. A lot of people, it happens so gradually, they don't know what's happening. They say to themselves, oh, it's just because I'm getting old. I can't do that anymore. Well, a lot of times it's because of a cardiac issue. But once that's repaired, once that is fixed, that person needs to go through some sort of exercise program, a safe, medically supervised exercise program to make sure that whatever issue they had before doesn't reoccur or doesn't happen while they're exercising on their own. And that's where cardiac rehab comes in. So cardiac rehab and TMC cardiac rehab, it is appropriately placed at the El Dorado Health Campus, TMC's El Dorado Health Campus, right off of Wilmot. And the reason why it's there is because there is plenty of parking. There's a lot of parking there. You guys drove? Well, I guess seniors, they have parking here. They have if it was a more popular presentation, if somebody else was talking, it would be hard finding parking. But typically at TMC, I mean, if anybody's ever had an appointment there, you drive around in circles for an hour looking for a space, and then just kind of give up, go to the valet, and give your keys to the valet and have them park. But and so at the El Dorado Health Campus, there's plenty of parking. And that's why cardiac rehab is there. It's also a little bit more centrally located for people that are on the east part of town, for people on the west side of town, for people on the north side of town. And as you know, the south side, Vail, Green Valley is growing like a weed, growing like a weed down there. And so it's also convenient for those patients as well. But anyways, that's where we're located at the El Dorado Health Campus. And so cardiac rehab, it's a monitored, progressive, controlled exercise program. Cardiac rehab consists of several types of individuals. Now, I mentioned myself and some of my colleagues and the other physiologists, but we also have nurses, we have doctors, we have dietitians, we even have endocrinologists at some point, because some of our patients are newly diagnosed with diabetes. And it takes a little while for people to get a handle of that. And so if need be, we can write referrals to see an endocrinologist as well. Yes, sir.
I'm sorry I'm late. So the question I have is what you just did before, and I want to bring it up now because I'll forget it and you'll forget it. I got 3 stents in me now.
Yes, sir.
And I got, I don't know, 1 or 3 or 4 re-stented.
Yes, sir.
That's been like 10 or 12 years ago. Is there a reason to check to see if they're okay, or is it if I'm alive and well and can be reasonably good talking, then I'm okay?
Yeah, so of course, I mean, hopefully you have a good relationship with your cardiologist. And how often do you see your cardiologist?
I have an appointment with one right now, but the cardiologist I saw last time, I got the impression he didn't even know what a stent was, but I'm sure he did. But
Sure.
I asked him 2 or 3 times and he didn't answer anything.
Well, so the best person to answer that question would be the cardiologist. But in a lot of cases, now I'm just speaking generally, if you are symptom-free, if you're not short of breath, if you're taking care of all your daily activities, if you're not having any issues, then your cardiologist is going to say, well, let's do this test. They might do one test just to see how things are going. But otherwise, he'll give you a big old get out of here. You guys have heard that, right? Give you a get out of here? Yeah. That's what most people want to hear. Get out of here. And so, but yes, because, doing an additional procedure in a lot of cases can be more risky than just letting you live your life. So, yeah, but check with your cardiologist. I'm going on record saying check with your cardiologist. Okay?
Just some cardiologists I've been to, I don't even think they know the word stent. I mean, I know that's stupid to say, but
Sure.
I asked questions about it. And the guy who put him in retired. He was in Banner.
Okay.
He was good. He retired. I wanted to go back to him. But his famous saying was, we'll never know what's happening until we go inside. He wanted to stick that thing right up. No matter what I said, oh, yeah, man, stents are plugged up. We got to redo it. But that's his method.
Right.
And now I talked to a couple of heart people, and they I don't know, like Banner had a lab just for this place you're talking
Sure.
about. Must have a lab just for stents, right?
Well, there is a cath lab. Yes, sir, right here at TMC.
We'll save this conversation for afterwards, Glenn, so that we
Yes.
can get back to the
Yes,
presentation.
yes. But yeah, we'll talk a little bit more. So anyways, cardiac rehab. Once again, it's comprehensive. We have a lot of different professionals that are associated with cardiac rehab to answer questions, to refer people to get remedies as well to any sort of specific problem that the patient might have. But, we also try to be very effective in the way that we do it. And the way that it's effective is we do encourage patients to come to cardiac rehab at least twice a week, because it is like going to the gym. And in order for going to the gym to be effective, just like cardiac rehab, you have to be consistent. You have to show some sort of progression as well. If we don't see that in you, that's what we try to encourage. Now, comprehensive, of course, we talk about diet, We talk about nutrition, nutrition, that is diet. We talk about medications. We talk about follow-ups with your cardiologist just to make sure that everything is going right. And at cardiac rehab, we utilize a small EKG monitor so that we can see the progression of how your heart is improving with each session as well. We follow your blood pressure, we follow your heart rate, we follow your RPE, your rating of perceived exertion for each session. We also follow your exercise progression. We give you a exercise workout card that we keep. We keep that card. We don't let you take it home because people will start writing stuff on it. No, we keep an exercise card to ensure that your progression is upward. And if we start seeing flat spots or if we start seeing people decrease, then we start digging a little bit more. Okay, what's going on? Why isn't this person progressing? Is there something physically not going right? And so that's what we do at cardiac rehab. It's very, very inclusive. We try to do a lot of things. We do, oh yeah, I saw the word patient assessments. Every 30 days, whether or not you have come to us and talked to us about how things are going, every 30 days, without fail, we will pull you aside and we will ask you, we will tell you, we will inform you of your progress. We'll ask you how you're doing. We'll ask if you've had follow-ups with your cardiologist. We'll find out if there's any medication changes. And that's outside of, you talking to us every time you come to the clinic. Every day, twice a week, some patients 3 days a week, when they come to the clinic, it's an open conversation every time. Hey, how you doing today? Well, I'm doing okay. I didn't sleep well last night. I think one of my medications are off. Well, what are you taking? Blah, blah, blah. And that's where it goes. That's what cardiac rehab is about. If something's wrong, we get on the phone. Hello? Dr. Dewalt? Yeah, I have Mr. Smith here. Yeah, he's not doing so well. Oh, okay. All right. He'll be there in 30 minutes. Whereas if you go home and you try to call Dr. Dewalt, you might learn the words to the waiting music, right? For the on hold. But typically, cardiac rehab serves as that between yourself and the cardiologist as well. All the issues that we find, we get immediate responses. Patients that come to us and say, hey, I'm short of breath, immediate response. And immediate, I'm going to say like one business day anyways. Typically, if a patient calls, it could be, a week, sometimes even a month before you get a response. So anyways, that's the other reason. So,
A quick question.
Yes, please.
Does the cardiologist have to be, is that an in-house
No.
cardiologist? What if your cardiologist isn't affiliated with TMC?
We will call them. Now, are you affiliated with TMC? I mean, it's a lot. Well, so most of our cardiologists are affiliated with Tucson Heart, Pima Heart, Pima Vascular, Northwest. It seemed like they're from all over the place. And so, yeah. The only time we have some issues is if your cardiologist is in Michigan or Washington State or something like that. But typically, hopefully, if you are in from out of town, you have a local cardiologist as well, just in case of emergence. Or if you see a cardiologist regularly in your hometown, hopefully you have a cardiologist here that will follow you as well. So, but yes, we contact whoever your cardiologist is on file, that's who we contact. But yes, like I said before, typically, we do see people that have had any sort of CT surgery, any sort of valvular surgery, stents, and then there's a whole myriad of other cardiac issues that we do follow as well. Oh yeah, and I've already talked about this, but yeah, we work with doctors, dietitians, endocrinologists, diabetes educators, you name it. That's what cardiac rehab is. So there are basically 3 phases to cardiac rehab. 3 phases. Before COVID, there were 4 phases. Phase 1, cardiac rehab phase 1. That's when you are in the hospital. In a lot of cases, we try to see patients before any sort of intervention as well. So you're sitting in your room, you're laying in bed in your room before you have a stent, before you have, CTS, cardiothoracic surgery. Cardiac rehab will usually come in, we try to come in and see patients just to give an overview of what to expect. While you are phase 1, we go in and we assess patients. We check on your vital signs. The biggest thing that we follow is your EKG. We make sure there are no EKG changes or ECG changes. That's how you can tell how long your doctors has been a doctor, whether or not they say EKG or they say ECG. If they say EKG, they've been a doctor for 30 plus years. If they say ECG, probably 5 years. but anyways, blood pressure, you check blood pressure, and then we check to see how you respond to any sort of exercise. And the preferred exercise while you're inpatient is walking. And so that's what we do most cases, even before surgery, but definitely after intervention. And I love seeing patients in the ICU. Love to see patients. Day 1 after open heart surgery, I'll come in and I'll say, "Hi, my name is Mike. I'm from cardiac rehab. I'm going to get you up and go for a walk." And they look at me like, "What? Are you crazy?" I'm like, "No, you can do this." And they can. That is the best thing for you after any sort of open heart surgery, because it involves using the large muscles of your body, the muscle pump system. It helps return blood back to your heart. Your heart doesn't have to work as hard. And as soon as you can start doing that, the better off you're going to be. And then ambulation is encouraged the whole time. Cardiac rehab, we're there to monitor how you respond to that ambulation, how you respond to that exercise. Now, and so phase 1 goes on until the patient is discharged from the hospital. And so some patients, they might be there 3 or 4 days. Some patients, 10 days, 20 days. All those days, as long as you are with cardiac rehab, as long as you're on our patient list, sometimes things change, but we will follow you until you discharge. And while you are in the hospital, that's when we write that outpatient cardiac rehab referral. We write it, not your doctor, we write it. It's electronically signed by your doctor on file, but we write that referral. We make sure that you get that referral to continue that progression after you discharge from the hospital. So phase 2. So phase 2 is after you're discharged from the hospital. Probably been at home for maybe 2 or 3 weeks recovering. And I'm just saying from CT surgery. Let's just say from stents, from valve repairs like the TAVR, it could be a week or 2. But anyways, phase 2, you come to our outpatient clinic. And that's where the controlled, monitored progressive exercise starts. And it's on a regular basis. Once again, at least twice a week. Most patients are awarded 36 visits. 36 visits. That's a half a year. I'm sorry. If you come 2 times a week, 18 weeks, 36 sessions, it could be up to 6 months when people finish that. Because of vacations, you're allowed to take vacations. You're allowed to go out of town. You're allowed to go to doctor's appointments. And we're all human. We're going to get sick. We're going to get a cold or something. And so, yeah, you're allowed to do that. You don't lose any sessions. You don't lose any. They just get tagged onto the back of it. And so 36 sessions. Now, after those 36 sessions, you graduate from the phase 2 program. After you graduate, then you're allowed to enroll into what is a phase 3 program. Phase 3 program, and I'm gonna, before I say anything more about the Phase 3 and Phase 4 programs, the Phase 3 program, because of COVID, was phased out. But there is hopes that it will start again. The Phase 3 program allowed patients that were no longer in the Phase 2, no longer required that medical supervision. They could use the Phase 2, they could use the outpatient cardiac rehab as their medical supervised chip. They don't wear telemetry. They can come and go as they please. And that's where the problem came in for COVID, because after COVID, we had to monitor, we had to control who was coming in and out of the building. And as far as I know, Phase 3 in a lot of areas was phased out because of COVID. But who knows? Hopefully it'll come back again at some point. And then the Phase 4 program, which I don't even have listed up here, but a Phase 4 program was for people that had a cardiac risk factor, high blood pressure, diabetes, you name it. People that had risk factors were allowed through a doctor's referral to start a Phase 4 program. And once again, the Phase 4, they weren't monitored at all as well, but they still had that medical supervision. They had that interaction with the medical staff to get information that they needed as well. And so cardiac rehab, yeah, it is exercise. Oh, I just talked about all of that, didn't I? But cardiac rehab is exercise. Yeah, you can do that at home, right? Right?
Yes.
You can. Yeah, but that's just exercise. The difference between cardiac rehab and just exercising at home or your own gym that you go to is this little thing right here. This is the monitor. This is the cardiac telemetry monitor. This is how we follow your EKG while you're exercising to make sure that your heart is responding correctly to the exercise. We follow your EKG from the moment you get into the clinic, you put this box on, you sit down, we collect a baseline, and then we get your blood pressure, then you start exercising. We get your blood pressure again during the exercise, but we're still following that EKG. And then at some points, and it happens at least 3 or 4 times a day, where we have to say, Mr. Smith, you're gonna have to stop. There's something going on with your EKG. We see something, and we use the word funky. We see something funky going on with your rhythm. And they stop. If it settles down, we allow the patient to continue. If it doesn't settle down, we call, hello, Dr. Giwala, yeah, it's us again. And we say, hey, this is what's going on. This is what's going on. And we send that to the cardiologist. Usually the patient gets a call that afternoon. They see the cardiologist. They do an echo. They do a 12-lead EKG. They do everything they need to do to make sure that that patient is taken care of. But anyways, that's the difference between you exercising at home on your own and exercising at cardiac rehab. I mean, you can even take your blood pressure at home, right? Yeah. You can even do your heart rate at home, right? In fact, we're going to do that here today. We're going to do one of our metrics today. I wish I could have brought that little box with me, but it would only be because it wouldn't hook up to anything. It wouldn't. But anyway, so this is an exercise workout card. Every day you come to cardiac rehab, we fill in that progression. We make sure that you are not static. We make sure your exercise is dynamic and progressive so that you're continually building your cardiovascular system. That's what cardiac rehab is all about, building your cardiovascular system to increase your functional capacity so that you can do more, so that you can take care of more business, so that you are more comfortable out in the world. That's what it's all about. And so this is your exercise card. We fill this out every day. You come in, you do the exercise that's prescribed. After that exercise session, we add a little bit more. And then it's continually progressing. Some patients in cardiac rehab, and I'm going to just use an example, on the treadmill, it's speed and incline. We have patients that start off at speed, miles per hour, 1.1 miles per hour, 0% grade. At the end of 36 sessions, patients are up to 4 miles an hour, 8% grades for 10 plus minutes on the treadmill. A lot of times, partway through that progression, the patient becomes unaware that they are progressing. They knew it was hard at the beginning, but once they got to that point where it was like, oh, I can do this. This is great. I'm walking. I'm doing this, and it's going faster and faster. They don't even notice that it's going faster and faster. And that's the other thing about cardiac rehab, is it is progressive. And a lot of times, patients they're not even aware that they're progressing. And that's what we like to see. If the patient comes up to us at the end of the session and goes, oh my God, this was so hard. Then we're like, oh, okay, maybe we didn't do something right that day. But it is a conversation. So I said a little bit earlier about the RPE. And this is RPE right here. Rating of perceived exertion or effort, however you want to say it. RPE. And it's based on a scale. Oh, I put the easy one up here. But anyway, it's based on a scale. The official RPE scale is 6 to 20. I should have put it up here. I didn't. I probably should have. 6 to 20. So at level 6, if I say how hard this exercise is, on 6 to 12, 6 is you're sitting on a couch watching TV. 20 is the hardest thing you've ever done. And if I ask you during exercise how hard this is, most patients will give me like a 10 or 11 or 12. And I'm like, all right, that's great, perfect. If a patient gives me a 15, I'll say, oh yeah, it's a little too hard. Let's slow down a little bit. We'll build up a little bit later. 6 to 20. Most patients ask me, why is it 6 to 20 and not this 1 to 10? I really should not have put this one on here. This is just the simplified version. It's 6 to 20 because the physiologists that originally came up with it studied about 500 college-age males and females, all of about the age of 17 to 20 years old, had them do exercise and then rate that exercise, how hard that exercise was. Now, if they were doing easy exercise, they were giving easy numbers. If they were doing hard exercise, they gave hard numbers. But the other thing that physiologist did was he took their heart rates. If they were doing easy exercise, their heart rates were like 60. If they were doing hard exercise, very hard exercise, their heart rates were 200. And so that chart now makes more sense. 6 to 20. If you put a 0 beside each one of those numbers, 6 to 20, so 60, 70, 80, 90, 100, that equates to their heart rate. And that's what equates to, I'm going to say, about 85% of our patients' heart rates too. So anyways, I never should have put that RP scale up there. It just makes it confusing. But simplified, when you're exercising at home, you can put the 1 to 10. How hard am I exercising? Scale 1 to 10. I think I'm going about a 5 or 6. That's good enough. Okay?
Is heart rate how many times a minute it's beating?
Yes.
Is that
Yes. Oh, I'm glad you asked. Hold on to that question.
okay?
Hold on to that question, okay? Let me see. So, yeah. Other things that we follow are METs. M-E-T. And that's metabolic equivalence. If you think of exercise as a sphere, a volume, it's the effort that you're putting into it. It's the speed. It's the resistance. It's the heart. All of that kind of thrown in together gives us that number of METs, metabolic equivalence. It's a little bit older research term, but in the medical field, they still use METs quite a bit. Every patient chart that I fill out in the hospital, there's always that little box. How many METs is the patient? Is the patient up walking around? They lying in bed, or are they transferring? And that's a metabolic equivalence as to how much activity that patient is doing. And so it coincides with that. So education, oh boy, I could spend hours just talking about the education that we provide. A lot of our education is about nutrition. A lot of patients, in the news a lot, we talk about how our diet affects our lives. We know that there is a correlation between high fat foods, high sugar foods, high salt foods, and cardiac health. I even think I gave a little talk about that at one point. Did I? Anybody? No? Jennifer? Okay, she's not paying attention to me. But anyways, yeah, there's that whole component of nutrition. So we do talk about nutrition. We talk about medication. A lot of patients, the doctor just told me to take this. They don't know what that is. Some patients, they think, well, if I take one, that's okay, but if I take two, it's going to be even better. And so we have to ask patients, if we see a very low heart rate, we see very low blood pressures, that's the first thing that we ask. So did you take your medication this morning? Well, yeah, in fact, it made me feel so good yesterday. I took 2 today. I'm like, oh, no, you can't do that. And in some cases, patients will be taking 2 of the same medication, but under different names. And so we have to make sure that that's rectified. But yeah, a lot of education about medications as well. Smoke cessation. Do I need to go into that? But we do talk about smoke cessation. We refer people to the ASH hotline, to smoke cessation groups, to specific doctors that can provide medication to help that. Diabetes, that's the other thing we do talk a lot about initially, but the official word comes from our diabetes educators. We try to educate people on, what needs to happen for your diabetes to get under control. And of course, lifestyle change. I will tell you, probably about 90% of our patients that come to cardiac rehab have never exercised before. Never exercised before. And it becomes a lifestyle change for a lot of people to regularly exercise, not just to improve their cardiovascular system to help them heal from their heart condition, but something to incorporate into their daily lifestyle. But yeah, those are big changes for a lot of people. So as I said before, some of our metrics that we use at cardiac rehab, we follow the EKG, inpatient and phase 2. Inpatient, we don't even look at the patient until we look at their EKG, just to make sure that what we're starting with is okay, it's baseline, it's not anything new. But that's one of our metrics we look at. The next thing that we look at is blood pressure. We follow blood pressure trends. If I take your blood pressure one time and it's 140 over 90, I'm not going to go, oh my gosh, we need to call a cardiologist. That's not that big a deal. What we follow are the trends. Or who are you regularly? Was she 140 over 90 the day before, and the day before that, and the day before that? Yeah, and if that's the case, well, okay, that's just who she is. But now on the other hand, if she's 140 a day, then I take it again tomorrow and it's 150, and I take it again the next day, it's 160, 170, 180, then yeah, there might be an issue. But I'm not concerned about one blood pressure being just a little bit high. I'm not concerned. And the opposite, same thing with it being low. If it's low, if it's 90 over 50, I'm not going to be concerned unless I see it still going low. And then I start to get a little concerned as a cardiac rehab physiologist. But RPE, of course, like we just talked about, your rating of perceived exertion. You know, how hard is this exercise? You know, are you dealing with it okay? But we follow that. We want to make sure that you are progressing, but also at the same time, you're not taking it easy. Some patients do figure out, like about halfway through, if they give us hard numbers, then we won't increase their progression. But we usually see through that kind of quickly. If they're laughing and telling jokes with their neighbor, and we ask them how hard the exercise was, it's, oh, it's a 15, it's a 16, oh my gosh. Well, I don't think so. Blood glucose. Patients that are diabetic, we take their blood glucose before and after sessions, just to make sure that their blood glucose is staying patent, making sure that it's staying within the normal levels. And SpO2, measuring your oxygen. We do that just to make sure you have adequate blood oxygen supply. Those are some of our other metrics that we look at. Now, this is kind of interesting. This is actual data that of patients that completed and graduated from a phase 2 outpatient cardiac rehab, 75% of those patients had an increase of at least 50% of their functional capacity. So I'm saying people that were completely debilitated, had a hard time walking from here to that door, we're now able to walk from that door to the parking lot around Costco to Walmart and all those other places just because of cardiac rehab. And I have people stop me all the time when I do see them in Costco and Walmart. They're like, oh my God, Mike, look, I'm not on a chair. I'm not doing anything. I'm doing this all by myself. And it's because of cardiac rehab. Part of it might be a little bit because of their surgery as well, but it's because of that. 73% had an improvement in their psychosocial depression as well. Because we do, at the beginning of cardiac rehab, we have patients fill out a questionnaire. It's called the HADS, Hospital Anxiety Depression Scale. We have patients coming in that are clinically depressed. When they finish cardiac rehab, no signs of it at all, especially when they fill out that questionnaire at the end of cardiac rehab, which that is a win. But you can look at this. I think you have that in your handout. But these are just some other things that turn up, when patients do cardiac rehab versus not doing anything after any sort of cardiac intervention. And not just, this is not, I wish I could say this was just for TMC cardiac rehab, but it's not. It's cardiac rehab overall. 91% of patients met clinical goals, maintaining a resting blood pressure of less than 130 systolic and 80 diastolic. And that's fantastic. A lot of our patients come in with really high blood pressures and really low blood pressures. Either one is not good, whether it's really high or really low. But having them come out of cardiac rehab with a nice, stable, moderate blood pressure, that's also a win. In general, cardiac rehab is associated with reduced mortality for cardiac patients. There was a metric that came out a few years ago that if you did all 36 sessions, there was a 1% chance of having some sort of cardiac issue. If you did 50% or if you did 18 of those sessions, it was almost 50% chance of a cardiac issue. If you did 2 sessions, it was almost like not doing anything. So the more you do, the better your outcomes are. And that's really what that research came down to. Let's see. Okay. I think we're ready for a little activity. You guys have been sitting there for a while, right? So this is what we're going to do. First of all, and people at home, you can do this as well. I'm going to go off camera for a second. I'm going to steal a chair. For this part, I'm not going to sit down. The first thing I want you to do is I want you to find your radial pulse. It's right there below your thumb with your 2 fingers. You got that? Everybody at home, do you guys have that? Okay, good. Now, what I want you to do is count that for 10 seconds. Are you ready? Is there a clock in here? I want the second hand on mine. Well,
Yeah, I'll time.
okay, you'll time it? Okay, everybody, ready, set, count.
Time.
Stop counting. Okay, now that number, I want you to multiply that number by 6. Multiply that number by 6. Okay? We're going to call that your resting heart rate. That's your resting heart rate. That's your beats per minute while you're resting. Okay? Now, this is going to be like a small cardiac rehab. I don't have the monitors, but we just took one metric. Okay? Now, what we're going to do is we're going to do some sit to stands. Okay? Are you ready? So what I want you to do is make sure you have a clear path in front of you. Make sure nothing's going to fall on the floor. But all we're going to do, and I will demonstrate first, all we're going to do is stand up and sit down. Okay? We're going to do that 10 times, or as many times as you can. At the end of that, I want you to find that carotid, sorry. I want you to find that radial pulse again, and Jen's going to count 10 seconds. Okay? Are you ready? Here we go. 1, 2, 3, 4,
Time.
5, 6,
Jen, stop.
7, 8, 9, and 10. Okay, find that radial pulse, Jen. Count.
Time.
And stop counting. Now multiply that number by 6. What did you get? Anybody? I mean, it's volunteer.
60, I think.
Okay. Okay. Yeah.
Jen threw me off.
I'm sorry.
So I mean, that's actually a good example. That's good. And this is where cardiac rehab comes in very handy. You don't have to worry about that at cardiac rehab. But if you exercise on your own, if you want to see that progression, those are the kind of things that you'd have to do on your own. But anyways, cardiac rehab, we monitor those metrics so that we can see that either you're progressing or that you might be having some sort of issues with the exercise. Now, that other number that I have up there, 220 minus your age, that will determine your theoretical max heart rate. Oh, sorry, next. So, this other number that I have, 220 minus your age, and that will help you to determine your theoretical max heart rate. This is the simplified version. There are some modifications to this formula, for different populations, for different activity levels, blah, blah, blah. But this is the simple straight line method. Now, once you subtract your age, that is the maximum heart rate that you would probably see doing the maximum amount of exercise that you can do. Okay? Now, when you exercise, you want to stay within a target heart rate. And that's typically 70 and 80% of that theoretical max heart rate. At cardiac rehab, we determine that. We know your age. We know, well, because it's a special population, we have a little bit different formula, but we know what that target heart rate is. And when you're exercising in cardiac rehab, we make sure that you stay between those numbers to make sure that you're getting the maximum benefit from cardiac rehab. Now, of course, I know somebody out there, if you're not saying it, but Mike, I'm on a medication that blunts my heart rate, that doesn't allow my heart rate to go high. And then that's when we use some of the other metrics, like RPE, to see where you are while you are exercising. We still use blood pressure as well. If I'd had enough blood pressure cuffs in here, we would have taken blood pressure before and after. But measuring this is the best thing. So before the activity, your heart rate should have been like resting. After that activity, your heart rate should have been a little bit higher. And that's in response to exercise. That's what we do at cardiac rehab. Now, since I'm here, it is medically supervised, so you guys are okay. But otherwise, a lot of people don't do that when they're at home, when they're tracking their own exercise, when they're saying, I don't need cardiac rehab, I can exercise at home. Does that voice sound familiar to anybody? Yeah. Some of the patients that don't do cardiac rehab, that's their voice. But anyway, so that target heart rate that's determined, that's what makes sure that it is safe exercise for you. You're not just exercising willy-nilly. You're not just going out and see how hard you can exercise for 10 minutes or 5 minutes or whatever it is. It is controlled. It is monitored. Oh yeah, so that's where we are. And I think that's all I have for you. Oh yeah, sorry. Yes. Thank you, everybody.
Thank you, Mike. So I do have a couple of questions I wanted to ask you. One was about, let's see. So what's the soonest that patients can expect to be active on their own after cardiac rehab? When do they sort of graduate, I guess?
Oh, after cardiac rehab? Well,
yeah.
Let me put it to you this way, Maya. After the first few sessions of cardiac rehab, that we have determined that the patient is progressing and that there are no ill effects of exercise, we will usually have a sit down with that patient and say, hey, when you are at home, this is what we want you to do. Because cardiac rehab being twice a week, that's great so that we can see a progression. But for exercise consistency, there needs to be more. And so we will encourage that patient to start exercising on their own the other days that they're not in cardiac rehab. And typically that type of exercise is just simple walking, just walking, not going out buying any fancy exercise equipment, not doing any weight training, going to the gym with their cousin down the street. No, just simple walking.
Great. Okay.
Yeah.
Now, does your max heart rate ever change after you've had a procedure, like a heart procedure?
Yes, it can for a number of reasons. Well, the first reason is depending on what sort of heart condition you had. If there was something that was preventing your heart to respond to exercise, then yes. I mean, we can see changes in heart rate, in EKG and everything prior to that intervention. And then the other thing is different medications can cause differences in heart rates as well, especially resting heart rates. There is a medication, it's of the beta blocker class called metoprolol. Metoprolol is one of those medications that will typically lower resting heart rates. It will blunt that exercise response. It'll blunt the heart rate response to exercise.
Interesting. Now, what if somebody is in need of, they've had a procedure, they're in need of cardiac rehab. In order for them to come to cardiac rehab at TMC, what's that process like? As far as I know, they need to have a referral, correct?
Exactly. They need a referral.
Okay.
And if it's a cardiac and, if it's something diagnosed by a cardiologist, the cardiologist can write that referral if they don't have any interaction with TMC hospital. The cardiologist can write that referral. Now, there is a list of qualifying diagnoses for cardiac rehab, and that's up to the cardiologist to determine if it is a qualifying diagnosis for cardiac rehab.
Okay.
But most of the patients that we see at TMC, they've gone through TMC hospital. And I would probably say at least 90% of those referrals are written by us. And probably 75% of those are written by me. So if there is a cardiac intervention and it is qualifying, you will receive a cardiac rehab referral.
Okay. Now, if somebody's got questions, I did want to put up the phone number if they were wanting to call to cardiac rehab. So I've got that here. It's 520-324-2727. And that would just be if they've got a question, sort of what the process is like. I just wanted to be able to share that. You're over at, I know you're in the hospital, but the cardiac rehab is located, and you showed a photo there at our El Dorado Health Campus. That's off of Wilmot,
Exactly.
just south of Pima, where TMC for Seniors used to live as well. We're not there now, but we used to live there too. So we were on that campus, so people may be familiar with it that way too. Mike, I want to, hold on. I think I got one more. Is heart failure a qualifying diagnosis?
It is, but there is a criteria for that. The EF must be below 35%.
Okay, great. Thank
With
you.
the EF below 35%. Yes.
Perfect.
EF, that is ejection fraction. And so the ejection fraction is usually determined through an echocardiogram.
Mm-hmm.
And typically your cardiologist will give you a referral for an echo. You'll do an echo, and then it'll come back with several numbers. But the number that is qualifying for cardiac rehab is below 30 to 35%. And that usually indicates some sort of congestive heart failure or just heart failure.
Thank you, Mike. That's great information as well. I am going to wrap up with our online audience and turn it over to you for any questions in person. Thanks for being here today.
Thank you very much, Maya.
Thanks so much for being here again. We will be back on tomorrow as well. So tomorrow it is the heart of the matter, navigating cardiac consultations and testing. That is for Thursday, February 13th at 3 p.m. It'll be with Dr. Greg Kashkarian with Pima Heart and Vascular. If you're interested in that class, please give us a call. Our phone number is 520-324-1960. We'd be happy to register you to either attend in person or online. We look forward to seeing you again. Thank you.